afternoon, ladies and gentlemen. It's given me a great pleasure to present afternoon session. We will start with Dr. Hafid Milhan. Dr. Hafid is adult hematology consultant at Prince Mohammed bin Nasser at Jazan. He is the head of adult hematology department at Prince Mohammed bin Nasser, chairman of regional hematology and VTE committee in Jazan, specialized in sickle cell disease, leukemia, and inherited blood disorder with over a decade of experience. He trained at King Faisal Specialist Hospital and Prince Margaret Hospital in Toronto, published multiple research papers on hematological disorders, sickle cell, and leukemia. He had actively involved in development of hematology service and care pathways in Saudi Arabia, and he is a frequent speaker in national and international conference promoting advancement in hematology care and research. Dr. Hafid will talk about addressing missing diagnosis, PNH, in MPN and MDS.
Thank you, Dr. Assalamu alaikum. Good afternoon, everybody. And thank you, Dr. Ahmed, for the kind introduction. And thank you, Dr. Hajar and the organizing committee for inviting me to be with you today. I'm going to talk about addressing misdiagnosis of PNH in coexistence in MPNs and MDS. So I will talk about two parts. First, PNH in bone marrow failure syndrome and PNH in bone marrow failure syndrome and PNH in patient with myeloproliferative neoplasm. The lecture will be light, short, especially after the lunchtime. So first part, as you know, the presence of PNH clones are detected in bone marrow failure syndrome with variable occurrence in aplastic anemia and MDS. One of the studies showed that in aplastic anemia up to 60% and in MDS up to 20% of the cases. In Belgium, a cross-sectional study, they showed another figures up to 33 or 43 were related to aplastic anemia and 6.8 to MDS. And the rate of positivity varies greatly between 4 and 40% and largely depending on the method and on the sensitivity as detected in UK cross-section study. Subclinical and small PNH clone in bone marrow failure syndrome has better response to immunosuppressive therapy in aplastic anemia cases, as we'll see in the next slide. Wing et al. Was found in his study around 35% of MDS patients, especially the refractory anemia, are positive for PNH, and 20% of patients with 5q syndrome. And it was negative in other subtypes of MDS, like ring sideroblast anemia, refractory anemia with excess blast, and in patients with frank acute myeloid leukemia, in MDS with myeloproliferative neoplasm, and MDS with myelofibrosis. As we mentioned previously or above, that PNH is more detected in MDS with marrow failure, and they express less aggressive course, and they are less likely to transform into leukemia. They carry on better prognosis, and refractory anemia has been the most common subtype associated with clonal expansion. In this article in 2021, Bruno Fatizio, he studied the clinical and prognostic significance of small paroxysmal necrohemoglobinuria clones in MDS and aplastic anemia. In his this is cross-sectional study of total 3,085 patients who were tested for PNH, and they studied in King's College Hospital over 20 years, almost 20 years, from 1998 till October 2017. They found around 770 patients who were PNH positive. So it represents around 25% of these patients. And they study different parameters for positive cases with BNH. They studied the clone size with disease category, particularly aplastic anemia and MDS, clinical and laboratory feature, and response to therapy, occurrence of thrombosis, disease progression, and survival. This table represents the demographic hematological parameters and the response in those patients. As you see here, that the median age for PNH negative patients around 55, and for positive cases around 47. MDS was found in 24% of the cases, and aplastic anemia in 44% of the cases. Combined MDS and aplastic anemia, 3% are positive. Acute leukemia, around 4% of the patients are positive for PNH. And thrombosis, it was occurred in around 13% of patients. As compared in PNH negative, little bit lower than the negative cases, but is more common in patients with MDS who are positive for PNH. Death is more with PNH negative cases as compared to 19% in PNH positive. On the right side of the slide, you will see the parameters for these cases in MDS and aplastic anemia. The gray box or the gray column represent the positive cases. As you see here, that hemoglobin little bit lower, ANC lower, platelet significantly lower than the negative cases, and LDH is higher than negative cases. The same in aplastic anemia. In the lower part of the slide, this represents the response and the outcome for the treatment. And you'll see in the positive cases, there is good response to immunosuppressive therapy and good outcome with hematopoietic stem cell transplant. And for MDS negative cases, of course, there is good response to Fidasa. They studied the overall survival over 8 years for those patients, and they found the PNH positive. They represent good survival as compared to the negative cases. And also they study the survival according to the clone size. And you will see the patient with 50% or more, they present good survival as compared to the patient with lower clone size. Again, 8-year over survival for patient with MDS either positive or negative. The positive cases again represent good overall survival, and the same for aplastic anemia. The positive cases represent good survival. They study or they classified the clone sizes for different category of different diseases of aplastic anemia, MDS, and other diseases. And as you see, for MDS, the majority less than 0.1, they represent around 37% of the cases, and majority of the patient with aplastic anemia in the range from 20 to 50%, followed by 1 to 20%. And rarely you will find patient, especially in MDS, they will have clone size 50% or higher. So the conclusion from their study that there is high prevalence, around 25% are positive for PNH with different clone size. Variable clone size in MDS, majority are very small to small clone size. And positivity of PNH at any clone size was a good predictor of response to immunosuppressive therapy and of good outcome after hematopoietic stem cell transplant in both diseases with favorable impact on overall survival. The presence of PNH clone correlate with trend for greater thrombotic risk in MDS patient, even in cases without overt hemolytic feature. Very brief cases from the literature. 55 years old male with fatigue, pallor, recurrent abdominal pain. They initially diagnosed with low risk MDS due to dysplastic feature in bone marrow. With time, there was persistent anemia and hemolysis initially was attributed to MDS progression. But elevated LDH and low haptoglobin level prompted the testing for BNH, and it was negative with clone size 10%. So the patient was treated as BNH with MDS and with eculizumab and iron supplementation, and there was significant reduction in hemolysis and symptom improvement. Part 2 of the presentation will talk about BNH and MBNs. And BNH as a solo is rare, but when it combined with MBNs, it will be ultra rare. And the coexistence of BNH with MBNs has been reported, but its clinical and prognostic significance and therapeutic management are still poorly known. And moreover, those two conditions share overlapping clinical presentation, and that make the recognition of these diseases by the physician is very underestimated. The prevalence of BNH clone in MBN patient is around 10% in some study, mostly in association with JAK2 positive myelofibrosis. And they carry around 35% risk of thrombosis. That is refractory to combined modality of therapy. In this study by Giannato, he studied reviewed the literature for the reported cases of myeloproliferative neoplasm with BNH. He found around total of 23 cases have been reported in the literature, mostly in myelofibrosis, 12%, polycythemia vera, 3 cases, myelofibrosis, 12 cases, polycythemia, 3 cases, MBN unidentified, 2 cases, and AT, 1 case, and CML, 1 case. They study also the molecular pattern for these cases is around JAK2 positive, 9 cases, and the remaining cases are negative. CALR, 2 cases, and MBL mutated is only 1 case. Also, they study the timing of occurrence of BNH is regarding to myeloproliferative neoplasm diagnosis. They found around 12 cases preceded, diagnosed initially with MBN and then diagnosed with BNH. 4 cases diagnosed initially with BNH and then developed MBNs. They had recurrent thrombosis or development of thrombocytosis and leukocytosis. And 7 cases, there were concomitant diagnosis of both conditions at the same time with presentation of a typical thrombosis or coexistence of hemolytic anemia and thrombocytosis. The schedule represents the cases in details. Sorry, I will skip it a little. So this case report from the literature, 48-year-old female with non-essential thrombocythemia presenting with DFT, initially thrombosis attributed to hypercoagulability from MBN, as it is well known to cause thrombosis in affected patient. But with time, there was unexplained anemia with mild hemolysis and overlooked during the initial workup. BNH clone positive as 15%, and the bone marrow biopsy confirmed the feature of 80. Patient started on anticoagulation with warfarin, started on complement inhibitor, ravulizumab, thrombosis resolved with improved hemolysis marker. And the lesson learned from this case that BNH in MBN should be considered in patient with unusual thrombosis or persistent anemia with hemolysis. So the question when we should consider BNH in patient with MBNs. Number 1, unexplained cytopenia in patient with persistent without clear cause, and also in patient with JAK2 negative, as we see in the previous study that only 9 cases were JAK2 positive and the remaining negative. So with unexplained cytopenia, JAK2 negative, BNH need to be ruled out. In presence of anemia with hemolytic picture in those patients, as in the initial workup, usually those patients are not anemic, apart from myelofibrosis. But for polycythemia 80, usually they have normal or high hemoglobin. So high LDH reticulocytosis and low haptoglobin as hemolysis marker should be looked at in those patients. Thrombosis, especially at unusual site, should be considered for BNH screening, and MBN patient with aplastic or hypoplastic feature, as may be combined with bone marrow failure syndrome, we need to rule out BNH. Unusual response to MBN therapy, either resistant to JAK2 or hydroxyurea or progressive anemia, should consider the BNH. Is there any burden over the patient? Dr. Amal, at the morning, she talked about the burden in generally for the patient, and Dr. Amal and Dr. Prof. Farja. From my talk, I think delayed diagnosis is number one related to disregarding association between the two conditions, as the BNH in MBNs, the coexistent is not in the top. I can see 3 differential diagnoses. So I can say is unforgotten diagnosis, mainly in patients with MBNs. The lab issues in those patients, as you know, LDH will rise in both conditions. In MBNs will represent the tumor burden, and in BNH will present the hemolysis. So persistent LDH, I think, need to be ruled out BNH. Reticulocytosis can be observed in cases of myeloid metaplasia, and anemia result of fibrotic evolution. All hematologists will thought about this cause or this differential diagnosis in patient with persistent anemia in MBN's patient. Another challenging that will make the diagnosis delay is unavailability of testing in many hospitals, and I think this is very important factor for as a clinician, that sometimes you will try to skip this workup. Clinical burden of the patient, yes, is there because of severe thrombotic risk that often will be refractory to usual treatment, and it usually require aggressive modality of treatment, including anticoagulation, antiplatelet, and C3 or C5 inhibitor. And by this, I will conclude, and thank you very much for giving me the chance.
Thank you very much, Dr. Hafid, for this excellent presentation. Now we'd like to call Dr. Hafid Malhan, Dr. Amal Hashim, with a session, a panel discussion will be moderated with Dr. Mohammed Al-Makadi. Dr. Mohammed is a consultant in hematology, stem cell transplantation, and cellular therapy, a consultant in King Faisal Specialist Center في المدينة. تفضل دكتور.
Assalamu alaikum, good afternoon. I have prepared a few questions. I think we've gone